Good afternoon. Welcome everyone to our December population health plan. It's at the top of the hour. I do know we have a full agenda, so I'm going to go ahead and get us started. Thanks for joining us. Looks like we have a pretty full house. We're up to 25 right now and still joining, so that's great. Sorry, I've been going since about 3 o'clock this morning, so if I have a little brain fog, it is not COVID, it is lack of sleep. I'm just going to point that out right now. So welcome everyone. I'm going to turn it over to Tina. You're going to get us going. Yeah, go ahead. I'll let you go. I know I have a few things that I'll talk about when we get to the homework part of it, but go ahead and get us moving.
Okay, thanks, Wendy. 3 o'clock. That sounds pretty awful. Welcome, everyone. I see there's 26 of us in the call. I don't see that many webcams. Actually, I see quite a few, which is great. It's really good to see your faces. This topic today is based on conversations that some of us have had related to managing quality improvement, managing population health management during a time of disruption, during a time of competing priorities and stress, and what can that look like? So we have this agenda put together. What we're going to do is we're going to go over, as we always do, the data that all your sites have been submitted. We're going to debrief on the homework from last session. And then I have a small simulation activity for us to go through with debrief. And then we've got two people who are going to speak a little bit how they manage the first wave, the first surge in terms of continuity, and how they're using some of those skills to move forward. And we'll have a bunch of dialogue with you guys and then debrief and leave in action. So the learning objectives for today are first to understand collective performance on our required shared improvement measures. Second, to learn about peer strategies for understanding site-specific population health gaps. So that's our homework debrief. Third is to describe how quality improvement can help manage staff and patient well-being during a pandemic, and that will be our simulation and hearing throughout the pandemic. So we also want to hear from you about how that good stuff. And then finally, we're also going to leave here being able to create a fishbone diagram to uncover root causes. That's what some of the back and forth has been about as it relates to trying to get everyone access to use the whiteboard. We're gonna see if that works. If not, I'll be doing a lot of scribbling. Okay. This is a lunch meeting. I get it. I know you guys are distracted. I know you have emails. It's kind of timely for this topic that we talk a little bit about distraction. I know you are busy. I know you have a lot of stuff on your plate. Some of you have been up since 3 in the morning. Your mind will wander. And I just wanted to give us 15 seconds to set an intention. So we have 60 minutes, less than 60 minutes ahead of us. What do you really want to get out of the next 60 seconds? So I'm just going to give us 15 seconds, set that intention, think about how you're going to respond to it. Like turn off your phone, maybe turn off your second screen if you're distracted by emails. So just 15 seconds, let's give it a pause and a bit of a thought. Okay, thanks for indulging me. I saw a lot of pause in the screen, so I'm delighted by that. Hopefully you guys set an intention, and that's going to be really good because I'm going to draw on you guys quite a bit today to use the chat, to participate in the activities, and then of course we have some conversation. But first, let's get to the data that all of you have been participating and submitting. I want to start by sharing this improvement data. This is going to be from the period of November 1st, 2019 to October 31st, 2020. So the most recent data entry we should see, unless if you're ahead of the curve, is in the October column. And just to note, I synthesized all this data on December 3rd, and the reporting deadline was December 2nd. So if you got yours in a little bit late, it might not be represented here, but it will definitely for the next time we put it together. Just a quick reminder that the purpose of measurement here is really to support learning and action to drive measurable improvement. That answers that second question in the model for improvement, the model for improvement being the model or roadmap that we're using for quality improvement. So you start with your aim, and then you measure against that aim. How will we know that a change is an improvement? Second, it's to promote shared learning and accelerate improvement across all sites. So when we can all see how we're doing, we can share better, and we can share some of the changes that we're working on and how that's leading to performance. And then finally, to support organizations to position for a future with value-based payment. So let's take a look at the first indicator here. It's the first required quality improvement measure, hemoglobin A1C poor control. What this represents, it's inclusive of all sites that reported for the month. And you can see along the bottom, excuse me, the bar charts along the bottom, you can see the number of teams whose data is represented in it. So of all the patients with diabetes 18 to 75 that had a visit between the measurement period, which was November 1st, 2019 to October 31st, 2020, this is the proportion of them for whom their most recent hemoglobin A1C was greater than 9%. Now, in looking at some of the data, we noticed that not everyone is collecting the same thing just yet. And last time we went over this, I cautioned that we tread a little carefully as we interpret this data, because teams are, in fact, as I said, just ironing out those processes for collection and reporting. So there's going to be a little bit of change, a little bit of volatility for the first few months, but it should really stabilize soon as we all come online and use the same consistent processes for collecting and reporting it. I did notice there's a few observations in November, and so I just want to ask everyone to take a look at the convention they're using for reporting data. I will be honest, I had to email Wendy to ask her and clarify what period goes in what column before I prepared for this. So I get that it's confusing. I just want to ask everyone to double check that they're using the same convention. So for each measurement period, the last month in the measurement period corresponds to the monthly column in the Excel spreadsheet. So the last measurement period ended in October. So the last column we should see should be in October. Now, some of you might be collecting more data, so you have that November data available. That might be the case, but if not, just double check on that. Any questions on that measurement period and what column to report in? Let me just check in the chat. Okay, cool. I mentioned that the data is going to fluctuate a little bit early on. I also note that there's 7 teams that have historical data, which is awesome. And right now, the median we're sitting at is about 26%. So we'll watch for that next time we come together. And I'll also promise for the next time we come together to put together more detail in a document for you to take a look at. These sessions are really short, so I don't want to, get into all the details, though I would love to do that. But I'll write that up in a report with what's the denominator and small multiples so that you can all take a look at each of your run charts. So the next required indicator is depression screening and follow-up. So this is a percentage of patients aged 12 years and older screened for depression on the date of the encounter using an age-appropriate standardized depression screening tool. And if positive, a follow-up plan is documented on the date of the positive screen. So we have the same number of teams reporting, same thing with the measurement period, just double check that. It's still early data, like I mentioned, same caveats apply. We have right now 5 observations, and to use run chart rules, we need about 10 to take a look. But you can see early on, we've got roughly a median of about 66%. And this is one of those metrics that by September 2021, when we're looking back, I think this is one that we can move. There's a lot more factors that go into poor control, but this is one of those processes that I think all of the sites can move fairly readily. And then likewise, depressive disorder monitoring, we still have a few teams that are coming online with measurement here. We have a median of 50% of patients with a depressive disorder that are monitored with a valid validated tool at least every 6 months. Again, same caveats of early data. Particularly as this is measure, you can see this is the one with the fewest teams that are reporting at present, but teams are coming online. And I read that in your narrative report, so thank you. That really did help me understand too that I know a few of you are just coming online with bringing in a validated tool, and a few of you are switching over to PHQ-9 as a validated tool. For those of you to whom that applies, I would still recommend you get online with measurement, begin collecting your denominator, how many patients have depressive disorder. And even if right now your numerator is 0, I would plug that in. That's your baseline, and you really can only go up from there. So come online as soon as you can with that measure. And then, of course, if you have any questions about measurement, check in with your practice facilitator, and we will come back to this again next week, and hopefully with more stability, we'll be able to ask more questions, to learn a little bit more, and I will promise to you a bit more detail next with a report. What questions do you guys have about the data? Was it helpful to look through? I see like it's not really a nod, it's kind of maybe. Well, hopefully, you know, as we have more months of data, we'll really begin to see the value of how we can use that to learn from the data, to share between teams, and we'll be able to do that more. So just some high level observations and things to remind us of. Check on the reporting convention. A few teams I noticed have updated from 30-day look back to 12-month look back. So that's awesome. Thank you for being able to do that. As I mentioned, if you haven't started a process like PHQ-9 depression symptom monitoring, still get your data collection systems online. I've got a note here about diabetes poor control. I've got a little typo in there, versus labs monitoring. Just make sure that when you're collecting and reporting, you are putting in like data into the right data definitions. And then when viewing the data, expect a few more months of volatility. Okay, thank you guys. I'm going to now just pass it over to Kathy, who's going to lead us through a debrief of the homework from last session.
Thanks, Tina. Again, the same situation. I looked at the homework on December 3rd, so I may not have captured everyone who turned that in. But the homework was basically to ask you to look at those patients for whom we're tracking measures, haven't you seen, and trying to link them, as we talked about, trying to link them to care providers and teams if you actually are managing teams within your clinic. And we were trying to get a sense of, is the load distributed correctly, and about how many patients do you have that haven't been followed up or out of care, especially because we're all dealing with surges of COVID and a lot of disruption in our space. So the next slide. So, and go ahead to the next one. So the first thing I wanted to say is that data trumps our assumptions. So what I loved about this, and I'm not going to read it all to you, but in a couple of you commented that you were surprised that despite all of the disruptions, you've been able to follow your patients, the large majority of your patients. And so I thought it was a really great thing that sometimes our data tells us things we do want to hear. And in this case, it's been great that you have been able to see as many patients as you have, despite the disruptions. So again, we tend to make assumptions without data. So this is good news. So don't be afraid of getting that data. If it doesn't tell you good news, over time, it will get better. But I thought these were great, especially from CBHA and Cascade. The next slide. The next thing I saw was what we're doing is working. And you see 3 teams that have almost perfect scores of following up with depression disorder in the last 6 months. So again, knowing that, I bet they didn't know it before. It's really fun to see that data. And you can actually take this to your team who is struggling hard with all of these changes and COVID, and really celebrate the fact that you're doing a great job with getting these patients back and following them up. What I would ask you is to think about what you're doing that's working, and to the extent that you can, really embed those processes in the way of work so that they stick, because whatever you're doing is working, at least in these 3 organizations. Next slide. And then I saw a lot of interventions, people thinking about ways to improve. They've looked at their data, they're not completely satisfied with it. So Children's Home Society, they're doing a great job monitoring patients' BMI. They've chosen that since they are not able to measure diabetes. And they're doing a great job referring to the PCP. And it's disheartening because they don't hear back from the PCP. So what they're doing is they're going to outreach on their own, and they're going to follow up those patients with an elevated body mass index. I should have said that. These kids are at higher risk for obesity and diabetes. And so they're going to follow up with the PCP or with the patient's family and find out how they're doing. Wanted to make sure that they're in care. Likewise, Catholic Charities is looking at an infrastructure. They don't always have the data that they need to act, and so they're working to get that infrastructure in place. Cascade is trying to figure out care needs by looking at pre-visit checklists, and Mid-Valley is monitoring quarterly follow-up for patients with diabetes. So again, saw a lot of work associated with the data, and that's exactly right. When you get the data, it's only good if you use it. So use it to celebrate, use it to tweak. Next slide. And then I just encourage all of you to think about how to really embed this habit, if you will, of collecting data, looking at data, analyzing it, seeing where you can make an inroad. That will increase the reliability of your processes and also contribute to its sustaining. Many of us have had staff challenges or staff changes over the last couple of years, so anything we can do to keep these systems in place will be great. The other thing that I saw is that the number of patients who are not getting the care they need is pretty small. And so when you're thinking about that, and as we go through trying to figure out what do those patients need, keep in mind it's not an overwhelming task. We can really focus our efforts on a small number of people and make a big difference in those people's lives. And then this really ties in with today's topic, which is now that we know who those patients are at greater risk, how can we really identify what's going to make a difference for them? And so that's the rest of our topic today. So we're going to build. If there's any questions, please chat them into the chat box. And thank you. Back to you, Tina.
Thanks,
Tina,
Kathy.
you're on mute.
Yeah.
Can I say one thing?
Yeah.
Yeah, I just wanted to say thanks for all of you who were able to get your homework, both the narrative, the metric, and the actual homework in. I know it took a lot because we were really busy with the surge and kind of just hit a lot of us like a brick. But I would encourage you to go ahead and get those in, and try to get those in on time. I know you're establishing your routines right now, but with the homework itself, that at the end you'll see that Tina will ask you to do. It's very important that you think about what is talked about today, what you hear from your peers, and then what you're asked to do within the homework, and do that within a short period of time. Don't wait till right before the next LAN. Part of that is because just if you were in your math class, because we all love math, you don't wait a few weeks to do your math homework. You try to get that done fairly quickly because the information is fresh on your mind. You're trying to do it. The other thing is when you start looking at the homework and it is asking you to gather data or critical thinking, it allows you to start to develop strategies for improvement. And all of that work can go into your narrative reporting for the WPCC. So it all ties in together, as opposed to having something for the population health plan and something for the WPCC. We really were intentional about mixing the two so that you're doing one set of work to really energize you and leverage the time that you have to really move the improvement forward. So with that being said, I do want to ask, currently we have the homework. We're not talking about the narrative and the metrics. I'm talking more about the homework piece that Kathy had just asked you to do. We would like to move that up, that due date up, and we're thinking either the Friday after today's call or in 1 week or 2 weeks. So I'm going to ask Mariah to launch a quick poll and ask you to decide when would be the best time for that part of the homework to be due. So I will let her get that ready.
So when I go to launch the poll, it says I'm logged in from another device. Your polling session is inactive. So I wonder.
I think I can launch it.
Okay.
There we go.
Perfect. So I have Friday after, 1 week after, or 2 weeks after. Remembering the sooner you can do it, the homework piece, usually the better.
So we've got 10 of 28 right now. 13, 14, 15, 16, 17, 19. I know there's a few of us that wouldn't be voting.
Right.
We got 21.
That's about right. That's 7, and there's about 6 of us on, so maybe 1 team.
Okay, so I've got 22. I'm going to end the poll now and share results.
So we are split between 1 week and 2. Can we split the difference and say that it's due that third Friday of the month? That gives you a week and a half. Does that work with everyone? Chat in yes, unmute yourself yes, nod your head yes. Feedback is always good.
So I can't commit to that this time because I already have my schedules blocked off from our medical providers, but I could make accommodations if we came to that agreement for next time.
Yep, I'm willing.
Okay, so yeah, I'm meeting with our medical team, one on the 15th, so next Tuesday, and one on the 17th, next Thursday, but I can tighten that timeline up next time.
Right. And Shoshana, I see your comment, if there are data needs, I do understand that you're relying on other people for data needs. So we can definitely work with you. Maybe you're able to get part of the homework done and upload it, but just note on there that you're waiting for your data peeps to get you the rest. Is that for you? Okay. The more time, the better. Right, and Shoshana, I'm willing to work with you. For those of you who don't know, Cooley Medical Center just went live with their EHR transition yesterday. So I'll say, Shoshana, you don't ever have to tell me that for the next 2 months. I totally get it. So I know when you're delayed, that's probably why it is, because you're usually really on time. Very well. We'll send out that reminder. So we'll say this homework will be December 18th. That Tina will do today. Does that sound good for you, Tina?
Sure. So just remind me. Sorry, I was thinking forward in the content.
Homework will be due the third Friday of the month, so the week after on that Friday.
Okay, sounds good. And then it sounds like maybe a couple of people who won't be able to meet that deadline this time, but will for next.
Yeah, just communicate with Mariah or I. If there's a delay because of something going on with your new organization, just communicate. We totally understand. I think I've only received, I did see one this morning. I had 6 yesterday. I only have 7 now. So with 14 teams participating, I would have hoped to see much more than that. So I still haven't seen the rest of the homework from half the organizations.
Thank you, Wendy. And that homework is meant to build. So the homework will feed into the homework for this session, which will feed into the homework for next session. And it's really meant to put you on a path towards doing some of the skills of the population health management and hopefully achieving some of the aims and the measurable outcomes that we've set. So I would, as Wendy already has, encourage you to get that in still. So now I'm going to shift us a little bit into the topic sort of that we're talking about today, which is based on conversations related to quality improvement during a time of disruption and during a time of competing priorities. What I have is a bit of an activity that requires some attention from everyone. And what I'm going to do is I'm going to go through this interactive choose your own adventure story of an improvement team. I'm going to set it up first, and then I'm going to pause at a few places where we have a choice in the action that we take. It might seem silly, but just bear with me because there's some key concept in this that I'd like to debrief on when we get there. So where there is a choice, I'm going to call on someone at random, and it could be you. So do be prepared with that unmute button. And I don't want to hear anything about I couldn't find the unmute. It's really simple. Don't feel any pressure. You can make any choice. They all end somewhere. So when I do call on someone at random, just unmute, or you can even use the chat box to make your choice. They have letters that correspond. And this should be pretty clear as we go. So let me set it up. Here's the story. So before the pandemic, the Sunnyside Clinic was actively participating in the population health LAN. They were seeking to improve the health of their patient caseload, or population, some staff refer to it as. They set up an improvement team and started to stratify their patients for physical and behavioral health conditions. When the pandemic hit, all of their in-person appointments were canceled. Information was changing daily, and the team really scrambled to get telehealth up and running. And while it was rocky at the start, new processes and new systems were put into place to make telehealth and COVID-19 screening happen. Attempts were made to reschedule appointments to telehealth, but they found that quite a few patients didn't want to do those types of appointments, the telehealth appointments. But as the initial surge of COVID-19 slowed, team members felt pretty tired, and management encouraged staff to take vacations over the summer. Some things went back to normal and more in-person visits returned. Does this feel familiar to folks? Yeah, okay, good. First choice. So the team decided to restart their improvement team meetings, but they kept canceling them as other things came up. So team members agreed to A, just carry on and try to make the team meetings work as much as possible, or B, commit to shorter 15-minute huddles every 2 weeks. Craig, what do you think?
B.
We're going to go with B, commit to shorter 15-minute huddles every 2 weeks. And just so you know, the carry-on team would have gone there too. Okay, the team really valued the time to process everything that was going on. And a topic that kept coming up was this feeling that a lot of patients were falling behind in their care because of the pandemic. So the team decided to E, generate a list of patients overdue for hemoglobin A1C labs and PHQ-9 symptom monitoring to review at the next meeting to see if the data confirmed their suspicion, or F, steel themselves for a rush of patients when the pandemic ended. Mary Louise, what do you think?
We don't know when the pandemic will end. Definitely, E, definitely getting data now and looking at it.
Okay.
Sure that.
Let's go with E. At the next team meeting, the team reviewed the list of patients and confirmed their suspicions were correct. Lots of patients were overdue for care, and it seemed to be getting worse. But because COVID-19 was now surging again, the team I wasn't sure they could do anything because so many patients didn't want telephone visits. They decided to table the issue to the next meeting to focus on the right now. Or J, use 10 minutes from the meeting to make a fishbone diagram to brainstorm all the reasons why care was overdue, including factors related to the pandemic. Or K, try telephone reminders to see if that could get more people back into care and on track. Paul, what do you think?
Can't find the mute button. I'd say J.
Sorry, what was it?
I'd say J.
Let's go with J. Use 10 minutes to make a fishbone diagram. Okay, yay. They actually all end in fishbone diagram. So we're gonna do a fishbone diagram just to get into practice, and also because it's gonna be part of the homework for this session. So we're gonna use all the reasons patients are overdue for care and include factors that relate to the pandemic. So what I'm gonna do is I'm gonna launch the whiteboard, and I am hoping that people will also be able to use it, but I'm not totally certain that you will be able to. So let me just add all people, oops. Now this is obviously really broad, and if you were doing a fishbone diagram, which we will, we're gonna narrow it down onto A1C labs overdue and people that are missing depression screening and follow-up. So that's going to be the homework. But we're just going to start really generally with people overdue for care. Now, if a fishbone diagram is new to you, what it is a brainstorming tool and sort of a root cause analysis tool. So thinking through what are all the things that are going on that could be contributing to the effect, which in this case is people overdue for care. And to help us think through that, a fishbone diagram has the bones, which are sort of categories of factors. So it could be provider level factors, it could be external factors that are getting in the way, like maybe incentives aren't lining up. Yay, and someone figured out how to annotate. So thank you for leading, whoever did that. What you can do if you do have the ability to annotate, you should have a toolbar. You can just use the text and start populating all the different reasons at your own site that some of these things are getting in the way. Could be patient level factors, like people don't feel safe leaving home, or it could be system level or organizational factors that are getting in the way. So go ahead and find the toolbox, the text, and start filling it out from your side of things. External factors, COVID-19, we have under patient issues, transportation issues, so not being able to access, providers out on vacation. Awesome, this is great. What else do you guys have? Is anyone use the chat box if you're having trouble locating that, or just add them in there and I can populate them. In the system, we have new EMR implementation. Connie's saying there's a drop down to annotate. Annotate should be at the top of your screen under view options. Limits on how many bodies are in a clinic, especially with small clinics. Yep, so there's some new processes there too as it relates to COVID-19. We've got finances under patient. I think I can move some of these too. Perfect. We've got under system, short-staffed, MAs, nurses, providers. What else? You guys are really gearing up now. We stopped doing outreach calls. I'm curious about that. Ooh-wee. We are cooking with gas. I cannot keep up, guys. This is great. Okay. You guys are clearly nailing the fishbone diagram. Anything else? No internet access I saw pop in there. Transportation to clinic. I might put transportation under patient level factors, but it could be external factors if we have community groups that sometimes offer bus passes and stuff like that, and they're closed due to the pandemic. Anything else coming to mind? Okay. that around. Providers out for vacation, burnout. Yeah, this is great. Okay. Thank you guys. That is a really great start. It seems to me like many of you are pretty familiar with creating a fishbone diagram. We're going to do this as part of homework, but then it's also going to feed into the next session, which Kathy's going to lead on how do we identify some of these, prioritize them, and decide what we do next, what we take on. So I'm just going to save this and then we can share it after the call. Okay. Thanks, everyone. Oh, we still have some more coming in. I'm going to resave it. So is everyone sort of clear on the value of a fishbone diagram? What you would sort of, how this, yeah, I'm seeing lots of heads nod. So it's kind of like, you know, you're finding all the problems, but then these would lead to your solutions, right? The change ideas that you would test using PDSA cycles. Okay. Perfect. Right. I'll move. I'm just going to share my screen. Okay, wonderful. So I'm going to move forward. We did our fishbone diagram. And now just thinking through sort of that simulation that we did, some of the things we talked about, like, you know, you're busy, you can't meet as a team, you keep canceling team meetings, but you also find the value of staying in touch and breaking them down. As we went through that simulation and even the fishbone diagram, what reflections do you have from your own team? How has this been similar or dissimilar? How have you managed some of these things? And as everyone's thinking, some of the key concepts that I was thinking of when I was developing it and leading us through was the concepts around, there's a lot of tensions when we're balancing a lot of competing priorities, like communication too little or too much versus not having any information, and how stressful that can be. So even if we break it down into small chunks, that can be really helpful. Having a routine with quality improvement, you know, you have a predictable path, even if you have to scale back quite a bit during a pandemic, versus potentially chaos or something short of chaos, hopefully. Planning versus unplanned, having data and information versus making assumptions, and coming at change, which is coming at us from a proactive versus a reactive stance. So maybe rather than doing a full debrief on this, I'd just like to do two things. One is to let you know that there was a handout that came as part of the package, and that has some ideas for managing quality improvement and population health management during disruption. It has some of the key items that we talked about, like having short huddles, but it also has outreach calls and a few other ideas that we curated. Some of you have tried these, some of you haven't. Some ideas might not appear that you've done, and we'd love to hear those because we can add it. This is very much a draft. And then the next thing is that we have some breakout groups, and that's where I'd actually like us to continue this debrief. So we have behavioral health and a primary care group we're going to set up. Jamie Hilliard with Catholic Charities is going to kick us off in the behavioral health group. She's going to share what worked well for them during the first phase of the pandemic and what they're doing to replicate that. And Stephanie Dallin with Moses Lake Community Health is going to kick us off in the primary care group on the same questions. So let us move into the breakout groups.
Okay, I have them all set up. So hopefully everyone is assigned to the room they should go to. If there's any issues, I will hang out here and let anyone else move, but otherwise I am going to open the rooms now.
Okay, and just one more point is they're going to be 10 minutes and then we'll come back.
Okay, I'm going to set it to close automatically after 10 minutes. Let's do that now so that, okay. Thank you, Tina.
It looks like we're all here. So there's 12 of us, 9 on video. So Stephanie, I'm going to go ahead and kick it off to you.
Okay, I made a little thing just so I didn't feel like you guys were staring at me this whole time. So I'm going to share my screen, and I will have to admit that I was a little surprised when Tina asked me to talk, because quality improvement during a global pandemic, like, I mean, what? I just couldn't even think of what to say. And as we started talking, actually, she helped remind me that we had stuck to some quality improvement principles in dealing with the massive change in our operations. And it really brought me back to this quote that necessity is the mother of invention. And so if I had been tasked with changing 20% of our visits to a different type, a new thing, I certainly could not have done it in 3 weeks. But here we are in this. So we started out, this is at the end of February last year, what you see over here, with, of course, all 100% of our visits in person. Oops. And then COVID and changes to our operations. So we hit a high of 30% of our visits in those very early weeks of the pandemic being by telephone. And then we decided telephone wasn't enough. How do we see people in person but keep the exposure risk down? So we developed this parking lot visit. So you can come, pull your car up, we'll run right out like a car hop and take care of you and do what we can do. So then, constantly changing. Then winter, we got a little bit of a snowstorm and a couple, and it was very cold. And so we were like, hey, holy moly, what are we going to do now? So we had to, continue to make some changes. Then we started bringing people inside and having to keep our rooms closed for 1 hour, 30 minutes, 90 minutes based on the ventilation of the room. And we were physically running out of places to put people. So then we really had to do a push for telemed and telephone visits. And, when I told, I think it was the QI Affinity group, some of the stories we were doing, I took kind of our key quality improvement framework that we have and culture we have at Moses Lake Community Health Center really helped us stay on track. So communication, I cannot stress that enough in all of this. Our key decision makers met daily at the beginning to really refine real rapid cycle PDSA. We'd try something for a day and then you'd hear the 100 ways it went wrong and you would come up with something different. Okay, how can we fix that? And as the number of decisions that needed to be made lessened, we lessened our meetings. So right now we're still meeting twice a week, most weeks, to make those decisions. And you cannot tell people in enough ways, in many different ways. Over communication is not a thing. So make sure that make sure you have lots of different ways to tell people. We used our SharePoint right on the front. It was like the COVID decisions, here's what appointments happen how, here's the telemed instructions. Emails went out individually to staff, and we assigned leaders with a very specific task of informing each department of the changes, but also bringing back feedback from those departments back to the decision makers so that we can understand. Also at the very beginning, use data. So I developed that tracking spreadsheet after just about our first week. Okay, where are patients going? How are they being seen? What are the volumes? So we really early on decided what data was important to us and started to track it. And just like we did, Kathy talked about, really exploring the data that surprises you when you find something like, hey, all these patients are coming in still, or I'm still super surprised that our telemed acceptance rate is low. And I would say the third key to our success was being open-minded and committing not to solving problems forever, but for solving them for now. I can try something today and see if it works for tomorrow, but that doesn't have to be my forever choice. And really that's kind of the key takeaways, the short and sweet version of what I have, and just really wondered, what QI principles have you used? What was key? I didn't think about them when we were doing it, but now I see that we really did stick to a framework. And it's been really helpful to think about it in that framework, because then it seems more purposeful and more manageable.
I just want to comment on the patients coming in for telehealth. It seems like there's not more patient demand. Some patients want to come in and see their doctor. Like they do not want to convert to telehealth, even if they could.
Yeah, we have found that. Yep, they have the means, right? They're like, yeah, I know how to use that. I just don't want to.
Yeah, like we exceeded demand of telehealth.
Yeah, I'm fascinated by that, because even as a patient, I did a telehealth visit from my house 2 miles from the clinic when I was working from home one day. And I thought it was awesome. But, Heather and I on our team call patients and get them set up for telemed if they need that assistance. We're the facilitators for that. And even when some of our providers are working from home, and so we're calling to say, hey, this is a depression med follow-up. Like, what more perfect telemed visit is there? There's like, I can do a PHQ-9 just fine. I can do all of that. It's really symptomatic. How are you feeling? How's the medication working for you? Are you taking it? Yeah, our patients are like, nope, can they really do that if they can't like see me? It's like, oh, they can see you. Well, yeah, but they're not going to listen to my heart or my lungs. And I was like, with your depression visit, they probably weren't either. Like, okay. So I think we're still struggling to find the right value. What is the value to the patient of the encounter? And yeah, how do you sell that with telemed? I've been surprised.
And I wonder if with all the things that we do every time someone comes into a clinic, if we do them routinely, even if they're not for that visit, if patients just expect that, it's changing the culture, which we all know takes time, and we're doing it in a super fast way this year.
Yeah. I think we have some patients who really like it, and so I think that it's been valuable to them. But yeah, we do a lot we on purpose, right? We plan a lot of that incidental stuff that you do every time they come in.
Who else has any QI principles that they've implemented during this time that they would like to share? We only have about a minute left.
I think the whole COVID testing, trying to keep healthy patients in, sick patients on telehealth itself was just a whole QI for us. Figuring out what every staff person has to do, making sure everyone's on the same page, trying a few different things. Yes, I just think that whole process was a giant QI for us.
All right. Thanks, Stephanie. I think we're going to be kicked out in about, I can't see it, it's too small, but right now. So see you on the main room. So it looks like we got kicked back. Did they get more time than us or what? What happened to that?
I think going to what was just shared, that even this process of doing COVID and infectious disease, like after this, we're going to be a lot better infectious diseases, period, around changing processes that maybe we should have changed before a long time ago to stop the spread of like influenza or other things.
That's a good point. Anyone else have any other comments while we're waiting for the behavioral health group? Here they come.
We were right down to the wire.
Yeah, you see that.
Use that last second. Just going to, is everyone back then?
I think so.
So we've got just a few minutes left, and I'm really hopeful that you'll be able to take a look at that handout, but also that you heard something in the breakout session. Maybe in 2 minutes, if we could get a summary from the 2 minutes or less from the primary care session. Is there someone from primary care or someone's that would be interested in sharing a little bit about what they heard in theirs?
Can I ruthlessly call on Ton to give a little update on what we did in primary care?
Yes, we heard about a clinic that's going through keeping their processes in place, even when there's a lot of focus on other things, to make sure, even if it was short, even if it was truncated a bit, that they didn't lose their process. And then also looking at the COVID surge itself is a QI process, how we deal with infectious diseases, how we change our procedures and make things, improve things as things go.
Great. Thanks, Ton. And then from behavioral health group, the one that I was in, is there someone that just wants to share a little bit about some of the things they heard in that group?
Well, I heard that more people or patients had access to email than previously thought, and that staff enjoyed going through a process, the fishbone process, and found it useful and a bit of fun as well. And that some clinics are finding that their no-show rates are lower than they had had previous to the COVID epidemic. And others are finding that that's not the case and wondering if maybe it is the difference in population, maybe mental health versus SUD, that could be a difference.
Thanks, Loretta. Okay. So that is sort of the session, and where we're sort of going to go with this is creating a fishbone diagram as a follow-up step. And so we're going to ask that every site meet as a team and create a fishbone diagram, one for hemoglobin A1C poor control. What are all the causes or factors relating to that? And secondly, missed depression screening and follow-up. So that as a second one. If you're finding that you're not really sure how to do one of those, I would just suggest that as your homework item, give it a shot first. But if not, brainstorm at the very least, what do you need? What information do you need to be able to do that? Who do you need? What do you need? So create a plan for being able to do it. And then I also heard the no-show as one thing that Chris is thinking about applying this to too. So I would encourage Chris, if that makes sense to you, to apply the fishbone diagram to that. And we do have a template available. You can change the bones on it, however makes sense to your site. So we've set it up, but feel free to change it. And then think about how the COVID pandemic contributes to the effect that you're seeing, like poor control or missed depression screening and follow-up. I already mentioned, if you can't complete one, what do you need to do it? And then reach out to your practice facilitator for any support or facilitation of meetings that you might need to be able to do that. And I heard Jamie say that they had a lot of fun doing it with their team, so enjoy that. I love that you annotated that. That's great. So enjoy your fishbone diagrams as a team. It's a lot of fun. Hopefully you'll have fun. I look forward to hearing as a debrief item how fun it was. Okay. That is the end of the content for today. I wonder, before, I guess at the same time as we pull up the evaluation, are there any questions or any reflections that came up for you today? Do we have the evaluation built in, or it comes as a link? Is that right, Wendy?
I just sent the link in the chat box.
Oh, perfect. Okay, so please, the link to the evaluation is in the chat box. We really value your feedback and just based on what we hear. I have just a couple minutes left. Did you hear something that you can try today? Feel some sense of support from peers?
I know, as silly as it's going to sound, the idea of just that 10-minute meeting, like, it just always feels like it has to, like, QI has to be a big production and it has to be super well thought out and we have to have all the plans and all the answers. But just like, nope, you can just look at a list over 10 minutes and make a decision that one person will do 2 things, and that's fine. It makes it feel so much more manageable.
Thanks, Stephanie. Yeah, breaking it down into smaller chunks, smaller than you think.
I was also thinking during the fishbone, think how populated that fishbone diagram that we did together was, and less than 5 minutes. And I was thinking, if you did something that even in a common area that you could even put it up and the people could walk away, and if they were thinking, they could go put something back on it, so you're not having to use the precious meeting time.
Great idea. As a homework item, you can put one up in the hallway and get people to add sticky notes to it. Homework done. Easy peasy. What else? Well, we'll send out the fishbone diagram. Wendy's already sent out the template, I believe, but we'll send that out. So that might be a good helping hand as you begin the fishbone diagrams or continue. I don't know if you already have some started, but I really value everyone who joined us today, your time. I know it's really valuable, and I really appreciate your contributions and sitting with us and thinking through this. The fishbone diagram will be used, we'll debrief on it at the next session. And as I mentioned, we'll use that to build on where we go next, which Kathy will help us think through how to use a Pareto analysis to think through what we're going to do to prioritize and tackle some of these challenges. Okay, that's it.
Tina, I just want to comment. Christiane asked about doing the fishbone on the depression, and I just want to expand on it. Thanks, Roger and Wendy Bradley, for commenting back to her. I think it's very applicable for primary care to fishbone the depression as well as the diabetes, and behavioral health to fishbone the diabetes as well as the depression, because you're both dealing with both. And think about it through the lens of how you see your patients and how you're collecting A1Cs, and the way a behavioral health does their fishbone, what comes out on it, it's going to be different from primary care because your lens are different. So I encourage you to do it both.
Thanks for catching that.
Yep.
Okay.
Great. Thanks, everyone. Great meeting.
Thanks,
Tina.
Bye.
Bye-bye.